So yeah, thank you for coming back so promptly. As I said, we started off with this thinking through stories about what the problem is and what medical and social complexity and looks like and how it intersects with our job as clinicians. And basically, this is what makes our work so challenging right now. What I want to turn our attention to is solutions and thinking about what our responses might be. And I can tell you from having been on this side of things that when you face such chronic, complex, really, really interconnected problems, as an ordinary clinician, it really can feel like it's all too much and you don't want, there's nothing that you can do. But I want to argue that there is something you can do. And all you need is a bit of help to know what to do. And that's why Hannah, Tammy and I have built WHAM. So I think there are some slides, aren't there? Hannah's second set of slides. I think that should be coming up, Kelly.
Kelly, could you share the second set of slides, the WHAM tools?
Oh, yeah, give me 2 secs.
Thank you.
By the way, Kelly is an angel, everybody, if you hadn't realised.
She organises us.
So I said at the beginning that WHAM is mad. And the idea that the aspiration is that in MAD we are making a difference. And what we believe in WHAM is that it doesn't matter where you are on the big scale of life, whether you are right down at the bottom, whether you are a patient, whether you're a service user, whether you are a junior clinician, whether you are high up and you're a manager and you're leading the NHS, it doesn't matter where you are on that spectrum, we can all try and make a difference. And that's what WHAM is all about. Hannah is going to, what we thought we'd do with this afternoon, this second little session, is to kind of take you through 3 different stages at where you might want to make a difference. So Hannah is going to start by thinking about what we can do in clinical practice. So with the patient there and then when you see them. Tammy and Gail will then think about what happens at a service improvement level. And then Mary will tell us how we can take that out of that into society. So Hannah, I'm going to hand over to you now.
Great, thanks, Goody. Okay, next slide, please. Okay, so a few years ago, I started doing some quality improvement projects in helping myself firstly, and also some of my colleagues with how we address health inequalities in clinical practice. And as per, I'll use some of the QI tools and take you through a few of these things quickly. And all of this is available on the WHAM website in a lot more detail. So this is just a really quick whistle-stop tour of a couple of the tools, but do go on WHAM to see more. But starting with a problem statement, and the problem we face is that paediatric healthcare professionals feel powerless when faced with child poverty. The gaps in our training, as Goody highlighted, and lack of info on what's available can lead to missed opportunities to help these families. So next slide, please. So how can we help? This is an example of a case you might see in A&E. But actually we see that in all walks of our clinics and all areas of our practice. So for example, 5-year-old AO with cerebral palsy is brought by his mum to A&E with difficulty breathing. He's not yet in school and mum seems very stressed by the situation. You've taken a full history and examination. He has a lower respiratory tract infection, but doesn't need to come to hospital. You can send him home with some oral antibiotics. But his mum's really concerned about the cost of getting him home. And then you explore that in a bit more detail. How can we help? So thinking about this case, can we move on to the next slide? I think the aims of my project originally was to get all paediatricians in this clinical setting in A&E in the acute assessment unit to ask about child poverty and offer local resources where appropriate. We use the model for improvement to do this, which is just kind of on the right of the screen here. The measures we used for the initial project was asking at handover the percentage of paediatricians who asked about child poverty, percentage of us who are aware of local poverty resources that we could offer, and then what resources we gave and patient feedback on those. Some change ideas I'm going to go through on the next slide on some of the things we tried. So next slide, please, Kelly. So how would you ask about poverty? So I would always ask this in the social history when you ask, do you have a social worker, or asking about domestic violence, along with those questions, things that we ask everyone. And there's no right or wrong way to do this. there's lots of ways that we can suggest on the WHAM website, and have a look to see what works for you. But what I usually say is that many people are struggling with the cost of living currently, and this can affect our health. Because of this, we are now asking all our families some questions on how they're managing and offering resources that can support them through tough times. Is this something you would like support with? And you can think about things specifically like housing and food. But that is something I often use as an opening question. So next slide. And then how would you go on to discuss poverty? Again, no right or wrong way to do this, but as you might have heard of this psychosocial screening tool for adolescents called HEADS, and we kind of adapted that for not just adolescents, but anyone, any family. So H would be for home or housing, and we can explore that. E is for employment, are the parents working, and education as well. A is for activities, or can they afford to do activities that the child is interested in. D is for diet, or exploring whether they have enough money for food, especially towards the end of the month when salaries or benefits run out. And also safeguarding, do they have a social worker? Are they already known to social services either now or in the past? So that's one way that we can explore these things in a bit more detail in the social history. So next slide. And what can we offer? So on the WHAM website, this is a national version of a signposting tool that we use. And there's 3 main categories. So increasing income, so things like citizens advice, debt websites and things like that. Accessing essentials, so these are things like food banks, healthy start, shelter for housing, and refuge. And then supporting well-being are things like mental health support resources like Happy Maps, Family Lives, the Mix, which is more for like young adults. Home Start is more for under 5s, but we've got a few different ranges, and these are just examples of things that you can signpost families to. But I think thinking about the case of the child AO, 5-year-old with cerebral palsy and a pneumonia, what could we offer him? So I think we need to explore the history in a bit more detail to know what they need, but also we could think about citizens' advice, making sure he's on the benefits that he's entitled to, so on the right level of DLA and also carer's allowance in his case. Healthcare travel cost scheme, because there's stress about the travel, but every hospital has this, and we can help the patients fill out those forms or get administrative staff to do that, or reception staff. And also Healthy Start for free vitamins, and also for food vouchers for healthy fruit and veg. And yeah, if they're experiencing domestic violence, charities like Refuge are really helpful. And also just to support them emotionally, psychologically, as Grace mentioned, those are like just areas where people can feel really alone. And things like Family Lives, Happy Maps, Couth, and Mind for maybe for older children as well as for parents would be really helpful as well. So there are things that we can offer. And next slide, please. So we've created multiple versions of this in multiple hospitals. So in Kingston, at the Evelina, Enfield, Haringey, these are a few examples. Also at Chelsea. So I've made that a bit bigger because I think these are like multiple PDSAs of this signposting tool. And actually, having spoken to Grace at our cost of living workshop at the Evelina, as well as other parents, they all said, actually, we want something simple, something with a phone number and an email. So 2 different ways of contacting the organisation. And we need people who answer the phone. We need people who respond to emails. We don't want to keep knocking at those doors. So actually for this version, which is Hammersmith and Fulham for Chelsea that I created, we've only got 3 in each category. They're specifically for children with disabilities. And also I would recommend you contact these charities before putting them on the signposting tool to ensure that they do answer, that they're still operating, they still have capacity to help. And like actually that does need to be updated around every 6 months. But honestly, this took me about an hour to do initially in Chelsea. It doesn't take you long. It's very and actually calling them, often they signpost you to other really good charities. So so I think it's something quick and easy, and something that we can adapt for any hospital anywhere in the UK. So moving on to the next slide. So here's a few quotes from patients after receiving the resources. Thank you, that's really helpful. Our social worker didn't tell us about these, but it's great that we can access that ourselves. Thank you for considering these areas of our lives too, were just a few things that patients said afterwards. So moving on to the next slide. And now we're just going to hand over to Goody again to talk a bit more. I mean, obviously, what I've presented was quite simple, but actually, this is a really complex issue. And I want to hand over Goody to explore some of the nuances of that.
Thanks, Hannah. So yeah, we've just seen some of the practical tools that WHAM offers. I don't want to take ages on this because this is quite conceptual, but there's one very important point that I want to make, which is that the purpose of WHAM existing is that we want to make what seems impossible, at least in some way, doable, right? In some way where each of us can take some part of the problem and have a go, right? And have a go at making things better. But what WHAM is not trying to do is oversimplify and reduce what is incredibly complex and complicated into something that's simple and easy, as if it can be fixed like this, with a single bullet. Because let me tell you now, if any of us believe that we can fix health inequalities with a nicely worded questionnaire, we need to think again, right? That is just not the way that this is working. And this thing is just to show you that medicine sadly does think in this very linear way, that if A causes B, then it causes C, and we need to just prevent C by tackling A, but that's not how it works. Next slide, please, Kelly. Because we know from hearing Grace's story and from what I said at the beginning that the social determinants of health don't operate like that, right? The interconnections are, well, they're meant to operate like this slide, right? This is how we think of the very many different layers that really result in a child's health outcomes. But next slide, please, Kelly. The truth is that it's very difficult to actually pick all of that apart and to try and think about what is it that's causing this and how to intervene. What I'm trying to say is that this work is incredibly challenging. And the reason that WHAM exists is because you can't do it on your own. We were able to do some of this work by being together and by helping each other, by feeding into each other's work. That's why we're here. And we would invite everybody who is on this, patients and service deliverers alike, to join WHAM, because it is about us all together trying to change things so that it is better. What I will say is that what makes our jobs and lives so difficult is that the system, the NHS, is not built to think about populations, and it's not really built even to think about people in all of their beautiful complexity. And so what we're fighting is complexity on all fronts. And the more that we can work together ultimately what we're trying to do is we're trying to tackle social justice, right? And social justice is a very difficult thing to tackle. The more that we can do that together, the better. So I'm going to shut up now. That is at the individual level, what we as individual clinicians can do. I want to now hand over to Tammy and Gail, who will talk about what happens at a system level.
Thanks, Goody. Just give me a minute, let me share my slides. Can you see my presentation? Hopefully that's a yes, because I've lost everyone's faces.
Yes. Yes.
Yeah. Okay.
Yes.
Thank you so much for having us today. As Goody mentioned, I'm Tammy. I'm one of the WHAM co-founders, but I'm also a paediatric registrar. And I'm delighted to be here with Gail Manning, who is our wonderful, wonderful play specialist, who is the lead of our play team and was really the key person in helping us set up our Children and Young Persons Patient Council at Norfolk Park Hospital. So I just want to mention before I start a few people that were really crucial for getting this set up, particularly Tom Holliday, who's the lead consultant on this, as well as all the patients and families who are members of our Children and Young Persons Council. So just to tell you a little bit about what the council is and who we are. So we set the council up in June 21, just coming out of the COVID pandemic. And we invited service users of all different ages to participate, and we advertised the council in all our different paediatric settings: outpatients, inpatients, the ambulatory unit, and the emergency department. And we also asked staff to nominate patients that they thought would enjoy or benefit from being members of the council. Most of our council members attend the meetings with either a parent or carer unless they're older, and then sometimes they do attend by themselves. The meetings occur roughly quarterly and they're virtual, They're normally co-chaired always by Gail, and as well as either one of our paediatric nurses or trainees. There's always a consultant present, but they rarely chair the meeting, and that's really so it comes kind of from the ground level staff. The patients and the members don't feel any pressure to kind of hold back on what they're saying because a consultant's present, and they're normally there just to answer questions and minute our meetings. We were initially planning the meetings to be face-to-face, but actually a lot of our patients said they had difficulty attending the hospital for various reasons, or meetings face-to-face. And because of their requests, we've continued the meetings virtually. All our members get a certificate after attending any meeting, and they also get a £10 shopping voucher in exchange for their time and expertise. And we discuss a wide range of topics, some of which we'll talk about. And during the meetings, we also have different activities for our members. We minute all our meetings, they're all anonymized, and then we send our minutes to the members first to check them and make sure they're happy with them. And then we send them around to the whole paediatric team, all the way up to the chief exec, our patient liaison representative. So we close the loop. These are just some pictures of some of the outputs that we have from our meetings. So in the middle, the white and purple document is an example of some of our meeting minutes. We try to arrange them in themes, so you can have a look at the front page and quickly recap about what happened, and then there's more detailed minutes. The box on the right is some examples of what will typically encompass and be part of our meeting. So we normally start off with an icebreaker. We include activities. For example, one week we spoke about NICE guidelines for babies, children, young people's experience of healthcare. And then we'll discuss particular topics, sometimes suggested by staff members, and also those suggested by council members. So for example, relocation of our outpatient services, or how procedures are happening and is there appropriate analgesia and play specialist involvement. And then we send out meeting minutes, but as well as that, we try to send them out in a bit more interesting format. So the top left-hand corner is a sketch note of some of our meetings. Notes, and then the bottom left-hand corner is a lovely picture from one of our council members that she did as part of the activities and meetings. And finally, the top right-hand corner is a copy of the certificate that all our members get at the end of every meeting. Twice a year, we try to feed back to both staff and members on the actions that we've taken as a result of our meetings and produce You Said We Did poster in various formats. So this is just an example of one, and just to kind of touch upon some of the topics that are covered. We had feedback from families that the resources for carers staying on our wards was inadequate. They had difficulty sleeping, really poor tea and coffee facilities. And as a result of that, we've managed to upgrade the parents' kitchen. We now provide all parents and carers earplugs and toothbrushes and toothpaste on the ward. Inevitably, most of our members are children with more complex medical problems or chronic conditions, and because they are the regular users of our services. And one of the feedbacks we had was how disability unfriendly a lot of our areas are, particularly our outpatient areas. And as a result of that feedback, Gail's managed to source more disability friendly resources, including 2 sensory trolleys, one for our inpatient area and one for our outpatient area. We've also written a letter to our MP because the hospital has a tube station, but unfortunately that tube station has no disabled access, which makes getting to the hospital really difficult for parents and patients. And then finally, we also try to feedback positive feedback as well. So we've had lots of lovely feedback from our members about how kind and caring our staff are, and that's all fed back directly to our members. So as I've mentioned, we do cover lots of different topics, but in all honesty, a lot of the reason the council was started was because of feedback from both staff and patients coming out of the pandemic about our outpatient area. So at the hospital, we had a lovely, specifically made for our patients, paediatric outpatient area with fantastic kind of facilities. That was charity funded by the local community. And during COVID, that area was taken away. And we had lots of feedback from both our patients in clinics and from staff about how unhappy they were that we didn't get that area back. So we used that as really the impetus for starting the council. So we did have a bit of a hidden agenda when we started. The quote on the bottom left is from one of our council members. I feel they've taken our voice and safe space away and shoved us in a new space in a corner. And we really wanted to make sure that our patients' voices were heard in a kind of more formalized format. And the council was really an opportunity to provide our patients and their families a voice and a platform to air their concerns. We were able to take their message directly to our chief exec. And as a result, we've managed to host meetings between senior managers and our council members and their families, where they were able to air their opinions. We've engaged a lot with our patient liaison lead, who's been really helpful and critical in helping arrange all these meetings. And a lot of our young people have told us that these meetings have been really important in allowing them to have more ownership over their long-term health needs, and by having the platform to air their voices and concerns about the services we provide. And as a result of the council, we've followed on with the meetings with a walk around of our paediatric areas, which we've done using the NHS 15 Steps Challenge. We had, during that walk around, 2 of our young members from the council attending, as well as a parent, a staff from our paediatric department, and it was led by our patient advice and liaison lead. And we shared the feedback after the walk around, and we're currently writing a report summarising that feedback. And the plan is to, whilst we won't get our old outpatient area back, we are reorganising our new one. I'm going to hand over to Gail here to talk a bit more about some other projects that have come directly out of the council, and also she might have a bit more to add on the outpatient department.
Hello everyone. Yeah, so some of our current projects we're working on. One of them is to get accessible changing areas. According to what we found out, there is no accessible changing area in our outpatients. And one of our patients brought that up, so we're working with estates to get that resolved, hopefully. Apparently it's a project that started and then dipped away, so hopefully we can get that restarted. One of our new patients came up with working with us to create resources for children with areas they've not visited before. So we've got some new areas within the hospital, and they said it'd be really helpful if the trust had some visuals that they could view on the website of the areas. So I'm working with the family to produce that and to produce more social stories and elements like that for children with additional needs. One of our doctors is working on open access cards. That's not my area, but she's working with another family. So there's been a lot of collaborative working with the patients and their parents outside our meetings to help things move forward. We also have had guests from the trust join us. So we've had our dietitian join us and our head of nursing, which has helped us to escalate changes. So we now have snack bags for the parents. So one of the feedbacks from the parents or families were that the parents weren't fed. So although we can't feed all our parents, we do have snacks for people we feel need them. And then the children mentioned about snacks. So the dietitian came to one meeting and she asked the children what kind of snacks they'd like. And the children said they wanted healthy snacks. So she went away and she produced some new snacks. And now the snack trolley, which didn't used to go out, goes out twice a day in addition to their meals times. And it's a really popular thing. And actually our cook loves doing it because it really helps her engage with the children as she goes around. So some very positive projects that were fairly easy to fix when you get the right people on board. Can I have the next slide, Tammy, please? One of our most recent projects was communication. One of our parents mentioned that when she was in hospital with her daughter, and her daughter was really quite poorly, when the doctor did eventually come to see her, he said, "I'm sorry," or he or she, I'm not sure who it was, "I'm sorry I didn't get to you sooner, but had a very sick person in resus." And the mum said, "I appreciate that there's other sick children, but I don't want to know that." It to be said in a different way because it made her feel bad. And it turned out that her child's condition escalated and her child did become that very sick child. So I'm working together with one of the doctors to see how we can make small changes as a team to improve communication. So can I have the next slide, please, Tammy? Nabila, one of our doctors, has devised some interviews. She's interviewed some children on the ward. They've been really quite informal, and some parents, and she's also taken it to NICU and A&E. And she's asked them things like, what's your overall experience of communication within the healthcare professionals? She's had replies like, generally okay, everything was okay. And then another question was, can you think of a specific example of a less good or poor communication? And a parent fed back, on my first presentation, before her child had the cancer diagnosis, I was unsure what to expect, and the team here didn't have any answers, as they had to discuss it with Gosh first. This was tricky as we weren't sure what would happen either. And I think that's a really tricky time for parents when they're in that time when they don't know what the diagnosis is. So I think one of our members mentioned last time, any communication is better than none. Just tell us what's happening, even if it is you don't know what's happening. Tell us, because not talking to us is awful. And then another question was, how would you like to be communicated in the future? So things like explaining how to take medication, and only telling us when we're being discharged once the paperwork's done. That's a common complaint. So Nabila has done some interviews. I've done some interviews. We've also worked with another mum who's on the ward, who is on the patient council, who's helped us develop the interviews a little bit. So some of the children questions were, I found it really hard to interview the children because they knew me. They tended to say, yeah, it's great, because my role is very different to the medical side. I generally do the nice things. So I've stepped away a bit. But anyway, the questions were, when you've been in hospital, how did it feel talking to the staff like doctors? Great, I feel very acknowledged and respected. And that was a really interesting reply from a child who'd been in and out of hospital with mental health issues and an eating disorder. And she told me how different she felt depending on what she was admitted for. And she's being admitted for eating disorder, she felt like she was ignored, but when she was admitted for a mental health admission, that she was listened to. So that was quite interesting. And what times did you feel good when talking to a member of staff? So someone said, it didn't upset me, staff talking to me. I get upset when I'm having a blood test because it hurts. And were there any times when, did you have any times when talking to staff that weren't as good as, or made you feel upset? So this child had this reply. Previous to that, she'd replied to me that everything was great, but then later on we were talking and she added, actually, when the doctor was removing my drain, although he was funny and we'd been joking before, I had to ask him to stop, but we made friends again afterwards. So next slide, Tammy. So we presented this to one of our meetings, and these were kind of some of the phrases we came up with together that the families thought were nice ways we can say to people. So the importance of smiling, having positive body language, saying hello, introducing yourself, referring to the patient by name. And I think one of the things I really find really hard, and I do it all the time, is calling the parents mum and dad. I just can't remember all their names, but yeah, I do try. Making eye contact, consider your tone and the rate you speak at, avoiding medical jargon. And one of the parents fed back to us how do we know as professionals that people have actually understood what we've said? How do we know their capacity to take in the information at that time, given the experience they might have had being in A&E, how stressed they are, or their level of understanding generally? So that was quite a bigger project than we'd anticipated. So we're working on that. Nabila is going to get a teaching slide together and hopefully submit it to conference and write an article on it. So that's where we're at that. So the other thing we've done is a play festival. So the play team hosted their first ever play festival in August. It was a massive project which we pulled off in about 6 weeks. We had to pull in loads and loads of favours from all sorts of people around the hospital, but our charity kindly funded it, and we invited children with complex health needs to come and just have some fun in the hospital. So the first hour we dedicated to our oncology patients, so they had a safe space, but actually they ended up staying for the whole 4 hours. And we just had an entertainer, we had games, medical games like bandage your teddy bear, how many syringes in the pot, a feely box, we had singing and dancing, face painting. One of our consultants came and he got sponged with wet sponges and paint. And our feedback was amazing from the families. Everything about it they enjoyed. They loved watching their children having fun. They thought we did a great job. One of the children really struggled because she was autistic and she found it really too noisy, but we got a nurse she knew from the ward to come and see her. Another child had a fit while he was there. We put him in a safe place, and when he was well enough, he came back and joined us. And I've since had feedback from families who attended who it was their only outing all summer because their child's needs were so complex, and they felt it was a really safe place to come and have some fun. So it was just a really lovely day, and it raised our profile as the play team and the importance of play and how we make engagement with our families. So yeah, that was our fabulous fun day, and we're hoping to do it bigger and better next year. I'll hand you back to Tammy.
Thanks, Gail. So we wanted to end off just by talking a little bit about what we feel the value of the council is, and really how we feel it's impacted both us as staff, but also from feedback that we've had from families. And I think that we feel that the council's really created a dedicated space to hear the voice of patients and families. It's not about us at all as clinicians or healthcare professionals. It's about what our patients and their families think that matters to them, and how they feel that we can improve their healthcare and how we can improve services for them. And it's really acted as a powerful driver for improvement, focusing specifically on what matters to them. So we often find that we were coming up with ideas for quality improvement projects and we were doing them, but they weren't necessarily what our patients would have chosen for that needed done, or would have told us needed to be done. So the communication project is a real example. I don't think we would have come up with that idea as staff, and I think we often feel, especially as paediatricians, that we're excellent at communicating and we don't need to work on our communication skills. And also we can use the council, and we often bring project ideas to the council to get feedback from them, whether they think it will add value at all. Below, there's just some quotes here from our council members. So our members told us that they felt that they'd been given a voice, both for themselves, but also to represent other patients and families in a similar situation, and that their opinions were valued. It's a really good opportunity for people to feedback and have an impact. It's good to hear back about progress made, and I know our messages are getting back to those who know how to make change. That was from one of our parents. I think our members appreciated the diversity of participants and the sense of community amongst our council members. Different ages, different issues, variable communication needs, and individual agendas. Can't believe it works as well as it does. It's as if everyone genuinely wants something to happen. And I feel strongly this exactly the same way. Our council members range from the age of about 5 to 16. Everyone has very different health and social needs, and really all our meetings seem to work well. Everyone communicates well with each other, respects each other, and are able to voice their opinions. And finally, surprisingly for us, but it was really lovely to hear that some of our council members felt that their membership positively impact their relationship with their illness. So attending meetings has given me more confidence to talk about my health with friends going through the same things. And a little bit about what we've learned from the council and why we feel that anyone can implement a very similar thing in their setting. So just to set the scene, this was set up in a large DGH, but without very many resources, and a very kind of mixed population group. So as I've said already, the council's not about us at all as staff, it's about our members, and we're really there just as facilitators of time and space for our members. We found it a little bit challenging to recruit our members at the beginning, and often we found that many parents didn't want to have anything to do with the hospital once they've left. Inevitably, it has resulted, as I've mentioned, in children with more chronic conditions or medically complex conditions being members because they're regular use of our services. It's important to cater to different age groups and keep activities fresh and varied between each session, and we don't really want it to be just a platform for moaning. We'll be realistic and honest. I think we all know that everything takes a really long time to change, especially in the NHS, and it is important that you're honest with your members at the meetings. Share the information widely and highly, as well as the impact. So as I said, all our meetings go all the way up to the chief exec. It's been a really great platform to get more senior management involved and aware of what activities are taking place within the paediatric division. We found that the council was great for interpersonal relationships among staff as well. So we've had lots of different healthcare professionals and members of the MDT involved with the council at various points, and I think we've all gotten to know each other a lot better. I think I speak on behalf of both myself and Gail to say that it's been probably one of the best projects I've worked on during my training. It's been a real pleasure to be a part of. It is fulfilling and it's rewarding and it's great. I really enjoy every meeting. And I could go on about how great being part of the council and setting it up was as really for a long time, but I thought just end with a short video which will hopefully work from some of our members.
I joined because I felt that it would be important to have a say in the hospital, as well as it gave me a voice, and I'm really glad I have joined because they've taken the things we've...
Oh, sorry. Ah, no. Bear with me. Where's it gone?
...said into consideration and other people on the council's opinions into consideration, and from that we're making change.
And also the doctors listened to me a lot. I said to my face specialist, there was only one toilet. And now they listen to me. Instead of one toilet, now they have two toilets. So they can explain how the hospital is. So then you can tell their life story. This patient council meeting is very important for little kids and for big kids.
Thank you, everyone. Hopefully you saw that and it worked.
Thank you both. Have you finished now?
Yeah, thanks.
Yeah, thank you so much. That was an incredible presentation, and what amazing work to have done, both of you, at Northwood Park. Gail, it's a real pleasure to meet you. I mean, you're clearly quite a special play therapist, I think, and it's no surprise that your patients obviously love you. What I will say is that this raised so many issues, which I think are really pertinent to this work that we're trying to do, which is the challenge is it's one thing, right, to try and change health professional behavior, but when we're trying to change systems, we have to involve the people who matter the most, right, which are the patients. And we don't do that anywhere near as often as we should. And when we do it, it's never done as well as Tammy and Gail did it. And so one of the things that WHAM is trying to incorporate into our thinking is how do we do co-production in a way that is genuinely meaningful and actually allows patients and service users to have a voice in a way that is equal and not weirdly hierarchical, where the doctors are really the ones who've got the power. I'm going to just post.
Or Goody, you've muted yourself.
Sorry, I've just put in the chat box the latest project that WHAM is doing called Powering Up, which speaks exactly to this, because we want to try and figure out how to do co-production with young people in a way that it would just emulate what was happening at Northwick Park. And I also wanted to just bring in Rhea again, because she happens to be part of the Powering Up team, but also because she's done loads of co-production before. And Rhea, I want to ask you just a very specific question, actually, which is like, what difference does it make to you as a patient when you are asked your opinion about how services should change?
Wait, just to check, can you hear me?
Yeah.
Yeah, okay, good. That's a big question. Obviously it means so much to even be asked my opinion, but I think it also feels quite intimidating. I don't personally, like, you know, Aisha was my doctor, and I saw her several times over a period of like 2 years, and I managed to, you know, had a really nice rapport, and I really trusted her. So that actually, when she asked me to do things like co-produce and go to all these things, I was like, oh, she's really lovely. You know, she is helping me become my best and healthiest self. Of course, I want to give back to her. So I was like, of course. But if it wasn't, you know, for that rapport in the first place, I wouldn't have necessarily said yes, if that makes sense.
Totally. And I think, again, it speaks to this whole thing of it's all about relationships, isn't it? Like if you haven't even made the effort to have a good relationship with your patient in the first place, like why do you expect there to be anything else that happens after, you know, in any other setting, right? Why would patients suddenly appear and be like, yeah, we're going to help you make your hospital better, if they don't believe that you actually care for them in the first place? Thank you, Rhea. I'm going to, because I'm very aware of the time, move us on to think about systems now. So we've talked about what individual clinicians do. We've talked about what systems can do collectively. And Northwick Park was a beautiful interdisciplinary, you had different types of people working together to make that happen, which is really lovely. Mary is now going to talk about taking over the world and how do we go for world peace, and thinking about the systems. So Mary, over to you.
Yeah, I think this is probably the worst week ever to be talking about world peace, isn't it? But, you know, there you go, right. I'm just, can you see my slides? Everyone just say yes.
Yeah.
You all good? Yep, okay. So I'm just going to hit the slide. So my name is Mary. I'm I'm a paediatric consultant at Birmingham Children's Hospital. I've been working in the area of discharge mainly, but also looking at improvement around children with medical complexity. I'm also co-chair of a collab as part of that whole work stream. And I just wanted to talk to you about a couple of things that we have learned on our journey around improvement. And this is not my work alone. This is work in collaboration with both young people and parents, but also different agencies and primarily my discharge team, whose work this is that I'm presenting. So when you look at the first statement, I mean, I really love this quote that actually, it's all about the story. And I think, we've tried to harness that today in this collab session, because actually, unless you think about the story and understand the story, I think you miss key insights in how you look at complex problem solving. And I think it has to go back, and that idea of taking it back to the people who have the most insight and also impact of healthcare systems. And I think we're key stakeholders in that, because we obviously have to fix the printer and have to write the letters and all the other stuff that we have to do to provide patient care. But I think it's around all these other things that WHAM have so clearly defined and put together as impacting on health and well-being. So if we start with the story, I think we can't really exclude the atoms. And I think when you look at the atoms, that is what helps us understand the way systems move together. So, for example, I think that, so in terms of saving the planet, I'm all for that. Would I have said no to a plastic bag before it cost me 5p? No, I wouldn't have. I'd have taken the free plastic bag every day of the week. But now, because there is a cost associated with that, I change my behaviour. And I think when you're looking at how we impact on young people and families, what we need to do is look at systems and look at how we can adapt the systems to make it easy. Okay, so when you look at patient systems, so there's this bit around, I've got an interest in ergonomics, which is basically how people interact with their systems, and there's a whole webinar around that I talk through. I'm using some of the slides to illustrate some of the points, but essentially the systems around patients involve physical systems like heights, like the fact that there aren't any changing rooms that are adequate for adult children, you know, in lots of areas. And then, so apart from that physical space of wheelchair access and logistics and all of that stuff, there's also the people that you need to interact with. And I think we heard that quite eloquently from Grace earlier around the different kinds of systems and people that she needed to interact with, and that's not just health. And this is one model that I really love and is part of a lot of the health patient safety movement, is around looking at how you organise systems and how you categorise some of these interactions to help you understand where the wins are and where the blockages are. And I think that's really important. So if I look at this in more detail, this is from a patient safety perspective. Actually, if you look at this sheet, what you'd have is Grace and the people that are caring for Adrian in this box here. So you've got the patient, but you've also got the family around the patient, and sometimes that's extended family, and sometimes that's social support structures, and then around that you've got this care team, okay, and then you've got all these other things that influence things. So external influences, your physical environment, again really impacted by your access to housing, access to food, your technology and tools, that might be your suction machines, I mean, a lot of children that have medical complexity have a whole pharmacy in their house, you know, they've got a big cupboard with, and when you see some of the pictures, you think, oh my gosh, how do you do that? Because actually, you know, they're on like 30 medicines a day at various points, and they're structured and given through the gastrostomy or not, or, you know, different ways of doing things. And there's tasks associated with caring for that child that are out with what you're normal. So I have 3 children. There are a certain amount of tasks that I need to do, washing, ironing, you know, like shopping, feeding, all of that stuff. But then there's an extra layer of complexity around caring for a child who will eat a bit differently or take longer to eat or need food accessed in a different way. Then it's around organisation, how you organise your work, and that might be around the systems around how you, I don't know, order a pharmacy drug. So if you're running out of Movicol, you have to order that. How does that system work? And all of this is swimming in this whole cultural pool. And I think this is just one way that you can look at how a child with complex medical needs lives in the healthcare environment. And when you're looking at systems, I mean, this is me on the phone to BT, just kind of, you know, my router doesn't work, my internet isn't working, I'm presenting on the CoLab this afternoon, what do I do? You know, and you end up getting really frustrated. And I think that's why I asked Grace this question earlier, because I think that these systems that you're being asked to traverse are not just, so this is one healthcare, this is using the SEEPS model, but looking at it in a series for a chronic illness, is that you have this one interaction with all the components that I talked about, but then you have a series of them with different healthcare providers, with different rules and different access points. And so when you're traversing that kind of system, and you know your scan hasn't been done in time for the appointment, or the appointment's been moved at last minute, but you have to pick up your kids, and it's all of these things are interacting. But then you're also going on this journey where you have this interaction at different times, and it's not linear, because actually you might have 2 appointments on one day and have to move one, or you might have you know, an educational thing that you need to be at, like for an EHCP, but then you've got the appointment and you need to have talked to this clinician before you go and see that clinician, and so it's not actually as linear as is portrayed there. And I think this is how I see some young, in fact quite a few, at various points of the patients I treat and their families, and it is really this sense of frustration and despair. Okay, and you know, and what I've put there is some of the systems. So apart from this healthcare system that we've talked about, this is a map of the Birmingham housing rehousing system with the red bits. It's not meant to be in detail, but it's just so you understand it's a complex system. And I think in the chat before we talked about how you know, services have shrunk, and I think what's happened is with resources dwindling, a lot of services that are there to support families put up barriers for families to engage because they're trying to conserve the resource. So if I'm trying to, you know, basically if I only have so much to spend or can only support so many families, I make it harder for you to access a house or for you to, you know, access a support worker or whatever. And we see that really starkly, actually, in terms of just even a basic thing like child protection services support. From one county to another, I work in a tertiary hospital. We get children from all over the county, actually, you know, in the West Midlands. And there is a very big difference between social care interactions across local authority boundaries. And you can see that, and that's around resource and mapping out and trying to boundary set. This is a figure of the EHCP planning pathway. Really interesting comment about Grace around language, and I think it's just trying to see how many of these systems a parent caring for a young person with complexity may have to navigate apart from health. This is there because I got an email this morning. It wasn't even an email, it was on WhatsApp this morning to tell me that one of my children had to be in a Stone Age outfit this Friday because it's Stone Age Day. I didn't really know that, but I've had to adapt to that. And that's, I mean, it sounds really trite in this context where you're talking about keeping a child out of hospital, but I think it's just to illustrate the point that all the other normal things carry on. You know, Christmas carries on, you know, your holidays carry on, your you know, people's birthdays and the way you have to navigate around that. You know, phoning grandma has to carry on. And so there's all this other stuff that is there in the complexity of life that we know today that carries on in addition to all these extra things. This is the healthcare system there. So on reflection, I'm just going to talk you through some of the solutions that we found as a team have worked. And I'm happy to have the conversation or have input with this with respect and with a filter of inequalities also. So I think the first thing, and this has been spoken to a lot in the session so far, is around engaging with people and really about authentic co-production. And I think the comments around the setup of the service in Northwick Park were quite interesting, because I think it sounds so straightforward, right? Anyone want to come and talk to us about the issues, please come and we'll have a chat. But actually, there are loads of barriers, aren't there? There's governance, there's engagement, there's psychological safety of staff to be able to talk about, you know, the gaps in the system that they provide. I think there's lots of different things that can stop that authenticity of the co-production. And I think that's really important, because I think we need to look at how we change that. I mean, in addition, we talk about this at the CoLab Exec Committee meetings all the time. Actually, we have a really helpful group of parents that are caring for children with medical complexity, like Grace, who are able to come and talk to us and help us with problem solving. But they often will come from a different demographic, because they often are native English speakers. They're often articulate. They can express themselves. They speak English well, and they are able to express themselves. That's not maybe reflective of the majority of the patients that we're seeing, or certainly I'm seeing in Birmingham. And so actually, how do we access proper co-production? How do we enable people who are less able to speak in the way that we can set up and hear? How do we do that? So that's part of understanding the problem and just really planning for that. I'm going to talk through these other things as we go. So other things are looking at connections. So in that model, you'll have seen things that connect together, and trying to look at how it's kind of almost like this dynamic model where things kind of get closer and further away, and actually trying to look at where the connections work well and strengthening those connections. And then rather than kind of getting upset about the whole thing being a terrible thing and just giving up, because I think that's very, you know, that's what a lot of clinicians will feel when they're looking at the complexity of it all. And And the other thing is to design out into solutions like the plastic bag. I mean, I'm not talking about payment, but I'm talking about designing the system to enable you to behave differently. We all behaved really differently in COVID, and I'll kind of illustrate that. And then the last bit is around measuring and getting the right data to be able to show change and impact in a language that people understand. So when we look at understanding and co-production, I think the two key things are being curious and being kind. And I think that's the thing that is really important when you're looking at engaging with people across professional boundaries, but also across, across the patient doctor interface. And I think that's really important. It's just that whole, oh, that's really interesting. Why is it that you're saying that? Or how is life for you? Or how do you access school, or whatever else? And I think that's really important. So this is a process map that we did in conjunction with stakeholders, young people, parents with who experience expert parents, allied health professionals from the community, children's social care from the disabilities team. And essentially we roadmapped a discharge from a child who came in with whatever, we kind of said, child with medical complexity, who we define as having a chronic illness, in our service, a chronic illness lasting more than a year with 2 system involvement or more. And one of the systems can be psychosocial. So it's quite an inclusive definition. And we tried to look at what is it that delays discharge? So what is it that means that these children end up staying a huge amount of time? And it's a key thing is around recognising this change in need. And I think that came out really clearly from all the parties. Actually, what social care were telling us is they needed to have this communication about this need at this point, and from there, their lead times were, they talk about, they have a different language around their timescales and how they needed to, their statutory requirements, and it's a very different language and a very different way of looking at processes. And so what they said is, as soon as we know this, we can then crack on with this, and this is our process. And housing said the same. You saw the map, it's really complex, but actually they said, well, the key is that you're on the housing register, then you can bid, and actually this is how we want the information about whether you need a house or not. Housing is a huge issue in Birmingham. And then there's bits around how we commission care and training, and that's outside all the complexity within our healthcare services around how people communicate with each other across teams and boundaries. So it was really interesting, but we wouldn't have gotten this level of information had it not been for the engagement of everyone that we felt was able to tell us. And we were missing commissioners in our initial plan, but we kind of tacked it on afterwards. But I think just having that awareness of all the different systems that interacted was really important, because it helped us then develop services around how we were going to minimise and shorten this journey by trying to communicate with services outside health really early on. And from that led to what we use now as a basis for much of our improvement work, which is around our stream. So our process map then becomes this palette of support that we try and give, and that we're trying to colour in a child's journey moving forward. And I won't bore you because I love talking about this, but so essentially, without that intel from key stakeholders, including young people and expert parents, we wouldn't have been able to really understand things well enough to set up the building blocks that then we were building on in terms of service. And in terms of connection, so I just wanted to talk to you around connections. And I think we all get frustrated around things that don't work and don't connect, and they should connect, and everything should connect, but it doesn't. And I think what I've discovered is that what you need to do is build on what works well. And the way to build on what works well is people. It's about the people. And if you find the right person, then you can start building. And that's really important. So one of our pieces of work was around connection. So you saw that process map, and actually, if I go back, you can see that there's this discharge meeting, like big things there. And actually, that's really important, because what that does is bring people together to talk about what the problems are and how they're going to solve it. And what you need is the key decision makers in those discharge meetings. And I think so around this connection bit is around how you bring people together, including young people and parents at the top, around how you're going to look at getting out of hospital or moving forward with care. When we look at bigger connections, so we got some funding, which seems 100 years ago now, for 5 years of a shelter housing officer to sit within our team. And what they did was help us understand both the process, which we mapped out there, but also the language and the culture within the housing sector. So actually that helps us understand why children don't get a house and they're sitting in the hospital. We're kind of, why aren't they getting a house? Why can't they get out? Well, actually it's because we haven't done this. We haven't talked to housing in the language that they need. So this housing officer helped us understand both the language, but also they were able to understand our children's needs and maybe adapt their systems a little bit. And we also developed links within the sector, which are only as strong as the people that are there. So when people move on, you have to re-establish those links, but it was really helpful. And we went from housing being one of the biggest barriers to discharge in Birmingham, probably about 8 or 9 years ago, to housing being something that is thought of early and actioned early. And ward managers will now come on our call, our like weekly call, and they'll be talking about sitting with the family and bidding for housing and whether they've been successful with a bid. That's all huge language change from 8 or 9 years ago. So actually people are being upskilled to be able to manage this aspect of what's stopping children getting out of hospital. And the other collaborations obviously are all here. You know how amazing CoLab is, but actually that's part of the whole idea of CoLab, is bringing people together to look at problems and strengthening connections. So that, for example, the setup that Northwick Park have created with their young person group, actually there's comments in the chat about people wanting to look at that and maybe translate that into their own environment. And actually, this is a forum by which we can learn from each other and move forward with some of the things. And also, that speaks also to WHAM. I've not put WHAM in here, but obviously that's the other thing with their heat map of national movements. So the third thing is around designing in solutions. So I'm going to talk about, so this is, we got all our medically fit complex children out of hospital within 23 days in the first wave of COVID. And that is because of a number of factors. Firstly, the risk perception from families around staying in hospital, but also a massive change in the barriers to children going home from our partners. And what we did was create a virtual space where all our established connections came, and we had kind of a bit of a problem-solving approach to getting children out, and we got everyone out within 23 days. And that was a real achievement. But I think it just goes to show you that when you design a system, or when a system is designed to help, it does actually help. But actually, a lot of our systems are not designed to help, they're designed to conserve resource. And the last thing is around measuring with the right data. And I think I just wanted to talk about, so there are really key things that you cannot measure, and that's the way that people feel, and that's around storytelling, and that's around quality. And I don't think there is a measure for that, and those stories just need to be told as part of the narrative. Okay, but actually we all work within a resource constraint, and so actually if we want to show a difference, I believe really strongly that we need to look at data. And in the same way that I can talk about children with housing barriers today versus 8 or 9 years ago, that's the kind of thing that I think will help when we look at how we advocate for resource and time. So this is an example of how we've used some of that data. So the team, not me, our CMIC team basically set up an equipment bank in the second and third waves of COVID. So it was a time at which children there wasn't this rapid discharge phase. COVID was seen as less of a risk, but there was still delays. And what we did was look at processes around equipment funding and commissioning. So if a child was going onto a ventilator, there'd then need to be an assessment, and then the commissioners need to take that away and go and get 2 ventilators because you have to have a backup, and that all needed to be commissioned and supplied. And then at the point at which you had the equipment, the young person could then go home. Okay, but actually there's this dead time, isn't there, in the middle where you've got a child and family stuck in hospital waiting for equipment to be commissioned and bought, but actually often they're well enough to go home, and sometimes within that time they catch another illness and end up becoming unwell, which is a travesty. So we ended up sourcing equipment, and I'll put that in inverted commas because it was kind of beg, borrow and steal, I think, equipment from around the hospital, suction machines, ventilators, things like that. So I've got it on the poster. And we ended up loaning between 1 to 6 pieces of equipment to 8 families before they got them commissioned by the commissioning teams in the community. And we ended up then being able to quantify that we saved 1,000 bed days by the length of stay. By the time they brought the equipment back to us, we could then say, well, this was the length of stay that we've saved because you couldn't have gone home. And that was a really powerful metric. And it was a powerful metric at exec level to say, because if you have a child on a ventilator, you can easily cost quantify that. That's apart from the quality impact, the impact on families, the impact on siblings, the impact on increased use of intensive care beds in intercurrent illness. There's all this other stuff that you can quantify, but sometimes it's about getting the language that you need to be able to produce the response that you want. So I think for me, and I was thinking about this because I feel like I'm in a room with lots of people who are very clever, and I was thinking about what things I would say, and I think it's starting with the stories is really important. You have to start with the stories, finish with the stories. Actually, it's all about the stories. So it's all about the people, and you need to be walking hand in hand in this journey with young people and families that are going through this. I think, Apple's done so well because they simplify. It's simplifying things. And actually, in the NHS, we're so bad at throwing things away. We throw nothing away. The fax machines are still there. We're really, really bad at getting rid of processes and saying, you don't need to do this, you don't need to do that. What we do is we have a look, something goes wrong, and we add on an extra layer of stuff that needs to be done. So actually trying to simplify processes for us, but also for our patients and families. And I think that's really important in the complex world that we live in. And then really, and I wanted to get a bit of Jackson 5 in, I won't sing it to you, but it is straightforward. And I think you just have to do it, so if you want to set up this young person's group like Tammy et al. Have done, just do it, and then it might fail, and then you learn from the failure, and then you go back and then you do it again, and then you go back and you do it again. So I think there is something around that trial and error that you just have to do, because I think a lot of us will wait until we've got the perfect thing that we want to try, and actually I think that's, you'll be waiting for a while, and I think actually just make the connection, make the change, and then just reevaluate. And I think that's probably my take-home message. And I think I really love this stream of work, because I think sometimes I feel like it's so bad that anything that I do will make a difference, and that's really not nice for people involved in it that don't have a choice. But actually, I think we all make a difference, even if it's to the person in front of you, by saying, you know what, I see you, I see that you're struggling, I see that, things must be tough for you, you're doing a good job, and that's really important. So I think you make a windmill in every consultation, but here we have maybe building blocks to make more windmills across the UK. Stop sharing.
Amazing. Thanks, Mary. Gosh, what's blowing my mind is how you've been able to do such deep work within the other sectors, like to think, like the work with shelter, for instance, and the housing stuff. To me, that just sounds like it's fundamental. It's what we said, right? In terms of the social determinants, we've got to go to the original cause of this stuff. And if you don't do it, you're not going to change things downstream when we're in A&E or in clinic or whatever. And so I just want to say, total hats off to you for getting together with a group of people and getting them to agree that that's what you were going to do. And I don't know, I mean, in terms of working with WHAM, we are more than honoured that we're at all even connected. But write about it. Tell us how you did it, because actually that's what WHAM is about. We want to share that learning with other people. Write a blog, or we could do it. I could interview you, and we could have a little, Clearly, you have no problem talking about it. So the point is that what I feel like CoLab is all about, and WHAM is about taking these jewels and then sharing them and spreading them around the country so that everyone can kind of benefit from the richness of it all. And yeah, just well done. That was fantastic. Now, it is getting to be a bit late, but there is still some time for talk and for discussion. And it looks like lots of people have been already putting chat in the typewritten place. But is there anybody who would like to speak up and just add their voice to what's been happening here? And obviously, if Grace is still here, I don't know if she is, but if Rhea would like to pitch in, obviously you guys get priority. But obviously anyone can speak up. So yeah, just go for it. I love this bit because everyone's always really shy and it's just really like awkward silence. Okay, Fiona, we've got a hand.
Sorry.
Hi, my name's Fiona Houlihan and I'm a professional nurse lead for Specialist Children's Services in the community in Greater Glasgow and Clyde in Scotland.
Hi.
I've been really interested in what you're saying today, and it's a subject that's really close to my heart, particularly with the board here. And what we've been doing over the last couple of years is creating a complex child's protocol with clinical guidelines on pretty much the same sort of concepts that you've been discussing today. It's about communication, collaboration and coordination of a child's plan. What we've been doing is focusing on the health side of things. First of all, so in Scotland, we've got, many of you will know, GIRFEC, which is getting it right for every child, which is that multi-agency approach to child's care. But what we were finding was in health, there's multiple practitioners involved. And they're sitting in acute, they're sitting in community, and they're sitting in specialist children's services. And it's about us in the first instance getting it right for the child and working together and coordinating that care. So that's what our focus has been on in the last wee while. So I'd be happy, but we're currently in the evaluation stage. So I'm doing quarterly evaluation reports. We've created Learn Pro modules and presentations for staff, and we're rolling it out across the whole board area. And the outcome is to obviously have that child protection element, get the child's voice in there, get the UNCRC and the parents' voice listened to. We've got all of that in the coordination plan as well. It was done in collaboration with parents with their feedback on what they thought of it. And we're currently out surveying the staff group as well at the moment. So that'll all be part of evaluation, and I'd happily share that through CoLab once we've got our full evaluation and let you know how we're getting on. But it's not been without its frustrations, because everyone does work at a different pace and everyone's got their different barriers to change. And it's been quite interesting hearing, because our main aim is to have a lead health professional identified for every child that's complex needs in order to coordinate that care and what they need. So it's not been without its challenges, but we are getting there. But I just wanted to share what we are doing up in Scotland.
Amazing, Fiona. I put in the chat that it'd be great if you could share like the protocol, but obviously any parts of anything that you can share would be amazing. I've always thought that I should be living north of the border in Scotland because I think you guys are doing such amazing work up there. So yes, let's be friends and let's kind of keep talking, because that sounds like incredible work. Does anybody else want to say anything in response to that, or in response to Mary's presentation? Dilip, you've been really active in our chats. How are you? And yeah, let's hear from you.
Thank you, Goody. Thanks. Yeah, I kind of I work closely with Mary in Birmingham.
Oh, you poor thing. Sorry.
Sorry. Can you hear me?
Yeah, I was just commiserating that you have to work with Mary. I'm so sorry about that.
That's fine. Don't worry. We live in borrowed glory. If you cannot innovate, imitate. That's my kind of motto.
Exactly. So, I mean, that's WHAM's motto too.
I'm coming into this. I'm the designated doctor for safeguarding in Sandwell, and one of the things that I've noticed for the past few years, and it's kind of slightly changed my kind of way of thinking. And that's why I put that comment to say we professionals actually don't challenge ourselves as robustly we do parents. So just to give an example, if a parent does not bring a child with complex needs on 2 or 3 occasions, we make it a safeguarding issue. We say it's medical neglect. I'll flip the question around. We all know how busy community pediatrics is right now, how short-staffed we are. So if a 6-month appointment does not come for 3 years, who's responsible? So I think, I mean, I kind of take your point that it's kind of, we within health cannot actually kind of put right everything. It needs to be a collaborative thing. And my plea is that we need to get health right, because we've got that locus of control. as much as I'd like to kind of say, I'd like to see politicians getting it right, education and local authority getting it right. I think we need to fight that battle, but I think we need to put our house in order first. So I think we need to look at it that way. And I think a lot of like what you've said and what Mary and others have said, we within the NHS sometimes kind of, make an attempt or to be seen to be co-producing things. I still think we come from a point of what can I offer so that, it becomes convenient to me as a clinician, rather than actually asking parents rightly what is it. So for, some of those that work in the community, you could have a child with the most complex of conditions, and yet the only thing parents want for that visit would be and I've had it where actually transport has been cancelled because your child does not have a complex condition, and it's a family with 5 children, with all 5 of them having different medical kind of complexity. So individually, yes, you could say this child does not qualify, but who's looking at it from a holistic parent and family perspective? So I think, it's great. I just kind of happened to kind of come across this on one of the social media platforms, and I said I need to attend this. But hats off to what you've been doing, Goody and Mary and the others.
Oh, thank you so much. Please join WHAM. You sound like you'd be a great addition to what we're doing. And I just want to pick up on what you said, because you're exactly correct. The reason that WHAM exists is that we are not waiting for politicians to do this for us. And you are right that health needs to put its house in order first, and there's a lot that we need to do before we even think about what's going on out in the wider world, right? So you're exactly right. And this is partly why why it's nice to have this conversation with like-minded people. What you said there about the fact that people have to wait years to have appointments in community pediatrics, like that should not be okay. That shouldn't be the state of things in like the 5th richest country in the world, right? That's not.
But the reality, Goody, is the way the NHS is set up, everybody is just focusing on the new. And that's precisely my point. So if you look at acute pediatrics versus community, I can say I've been a pediatrician, a consultant for the last 10 years. I can kind of say there's not a single patient that I see in my community clinic where actually I can put everything right in the first visit. It's actually the follow-ups that actually help. And we'd never look at the follow-up, do we? The entire focus is on, RTT is for the new appointment. Nobody is actually focusing on, do these children get a timely appointment? What's the thing? I can kind of say my own practice. I've seen patients 6 years apart, and what was meant to be an annual review, and you just think, how is that kind of allowed to kind of continue? So and that's precisely what I've discussed with some of the PRAM kind of network to kind of say we need to do a piece of work in community as to what's the delay with follow-up appointments. Because nobody is actually looking at them.
Yeah, that sounds really, really interesting. And it comes back to the whole thing about systemic complexity, right? Because you're talking about incentives in the system. And if the system is not incentivized to think about the chronic, the complex, and these follow-ups, then of course we're not going to get the resources to do it. You're 100% correct. And as doctors, we should be questioning this, right? We should be asking our managers about why resources are not being placed into these places. So please do that work because we need it. We need it done. Lisa's got a hand up. Hi, Lisa.
Hello. What a fantastic afternoon. I spent all afternoon sitting at my computer going, yes, absolutely, yes. So I many comments I wanted to make. I'll just very quickly say hello for anybody who doesn't know me. I'm Lisa Kaufman. I was also a community paediatrician for about 100 years. I retired from clinical practice a couple of years ago, and I co-chair the collab, following Mary's enthusiasm. I'm there running behind her. And my current other huge enthusiasm is communication. So I'm going to make a quick comment about communication, because otherwise people on the call will think I've lost it, because that's what I always do. But before I do, I just wanted to reflect about, you've talked beautifully about individuals and systems and politics, really helpful. There's something for me about how we take that step back. I suppose it's part of systems, and help healthcare professionals to get their heads around the fact that health inequalities are their business. And I wanted to pick up something that Una said right at the beginning, which is you're quite right. We can't all change everything. And some of us are such busy clinicians, it's not very much we can do. But seeing the inequalities and recognising them and acknowledging them and understanding the impact they have on the families, every single paediatrician needs to do, every health professional needs to do. So there's something about how we get that in right at the bottom and stop people thinking the disease is my problem. And people have said it just feels for a group of people who are so engaged in change, which is wonderful, we can actually do that as well to try and make every healthcare professional get their heads around this, even if they can't change it. So that was just something I wanted to express.
That is amazing, Lisa. So you're joining WHAM as of today, and you're going to help us to do exactly that, which is what we want to do. Is we want to seed this into medical education right from the beginning. And I don't mean medical education, I mean interprofessional healthcare education, so that everybody who ever comes across a patient in any shape or form does exactly that, and looks at health inequalities and thinks like that from the beginning, and then can automatically make those connections with housing and with social care, education, and doesn't have to be taught this or have to have a seminar like this to learn these things. You're absolutely right, Lisa.
Even if we can't change everything, there's that not getting defeated by the fact that we can't change it. And as Mary 100%. Said, it's about seeing the families, isn't it? It's about saying, this is really hard, isn't it? If I give you this new diet for your child, it's not going to work, is it? Because you haven't got enough electricity to put the blender on, or whatever it might be.
Totally, so, exactly.
Thank you. So one very quick comment about communication. Lovely piece of work asking children about how they found their hospital communication. Really hard to do. Fantastic. There's a huge amount of information out there about what patients want from their healthcare professionals. And I don't want to make anybody feel sad, but we're not very good communicators, even as paediatricians. And my plea as a communication skills trainer is, if you ever get the opportunity to do some communication skills training, do it. Because we're asking you as healthcare professionals to have the most difficult conversations with families in all sorts of really tricky situations. And we don't arm our healthcare army with as many skills as we could, and that makes me very sad. So it's just a plea. If you see the opportunity to get some communication skills training, I was going to say, even if you think you're a good communicator, even if you are a good communicator, we can always learn more. So that just like to add that. Thank you.
No, thanks, Lisa, and thank you for your enthusiasm. I'll be expecting to see your name in our membership list shortly. So, Una, I can see your hand is up.
Yeah, thanks very much, and a fantastic presentation. I feel like I'm with like-minded people, and the only person I knew at the start was Fiona, so I can second all the things that she said she's doing. We have a network for children with exceptional healthcare needs, and I'm another very oldie who's retired from acute paediatrics and have found a whole new area to learn about in complexity. And I think there is a case to be made for actually having a diagnosis of complexity, because I think it's misunderstood. And one of my biggest challenges is trying to get the various specialties to know about each other, because these families are moving around 6 or more specialty clinics, all of them telling them that what they are asking them to do is the priority, and the poor family are the only ones who have to take it all on board. So I think it's great that you've got Collab and what you're doing. But one of the things which I suppose it's my bugbear that I want to find if anyone else agrees, and it goes with your suggestion about education for all medical students at the very earliest stage to raise some of these issues, because I find that one of the difficulties I have is trying to get people in mental health and child mental health to actually understand that they're part of health. They always say it as, you know, health is holistic and it's no health without mental health, but then they tuck away all their health records and don't speak to anyone because it's mental health. And I think, again, the family are faced with trying to understand how to negotiate an area where we as paediatricians have no input. Maybe community paediatricians have a better chance than acute ones, but even their age ranges for when they offer care and what they see as the needs of the family seem to vary. And I would hope that if we got in very early in medical education to actually impose on the students the need for them to understand each other, then maybe Mary's idea of changing the world might actually happen. Thank you.
Oh, that's lovely, Una. And you're exactly right that that siloed way of thinking where everything is separate starts so early, and that we kind of just don't even question it as medical students, as doctors. We just think that that's how it should work. Although it is nice to be in a virtual room full of people who obviously think differently and don't want it to be like that. Mary, it looks like you want to respond in direct response
I just want to say, it's really interesting you should say that, because your name really rang a bell. And I've just Googled you, and I think you taught me when I was a medical student, Una, back in the day up in Scotland. And I think, isn't that amazing that actually I feel that in some way, all of that training will lead you down this route. So I think we are the change, really, and this is the change. So
I've been meeting patients who tell me that my babies from neonatal are now parents themselves. So I feel so old. Thanks, Mary. It's a pleasure to see you again.
Oh, it's too much. I'm gonna start crying. Bethan, you've got your hand up.
Hi everyone, I know a few of you on the call, but really good session. It's nice to meet so many new people today. So I'm a researcher. I just started at King's College London doing research around children with complex medical needs. One of my questions, I guess mostly to the clinicians on the call, is how can we support families to kind of navigate the system better? We know the parents are kind of often highly educated, white, middle class parents that are really good at making the system work for them. What can we do to support the families that don't have those same resources so that they can kind of navigate and get through the system? What are people kind of doing on the ground? Thank you.
So just before any clinician speaks, Rhea, what is the answer?
Put me on the spot.
Well, I feel like there's no point in us trying to make up the answer. Like, what would help you, or what would have helped you when you were trying to navigate the system, and your family, your parents? Like, yeah, that's really what Bethan is asking.
To be honest, I had a really good nurse, and she, like, after my first appointment, she took me and my mum into this room, and she kind of like explained how to navigate it. And I don't necessarily always think the doctors or like clinicians that you first interact with are maybe the best people to do that. I think someone like a nurse that has those interpersonal skills, almost kind of like more of a motherly, or like, do you know what I mean? They just have, I don't know, I think they just drop down a bit.
What are you trying to say, Rhea?
Sorry.
I don't understand.
I think they're just a bit more like colloquial, I don't know, less professional, I guess, is maybe what I'm trying to say. But I think because they are that little bit less professional, you can kind of like have a joke with them, and actually you're like, oh, I'm more willing to have a conversation where I talk about things about struggling about navigating my health or whatever. And I'm more willing to tell them because I'm like, oh, they seem really nice, like I want to tell them. So yeah, I don't know, that's kind of my experience personally.
Yeah, no, thank you, Ray. I'm sorry I put you on the spot, and I was obviously teasing you. So you in that you have raised this really interesting thing, which I hope Bethan at King's College you're going to be like looking into, which is this idea of partnership, and actually taking people along the journey with you and finding a way to navigate things in a kind of a shared, like I guess in a conversation as opposed to anything else. But I can see that Dilip has got his hand up, and he might have better thoughts than that even.
Thank you. Thanks, Bethan. Yeah, I mean, I think the answer actually is in your question, isn't it? We have created a system where actually you need to be articulate, you need to be kind of speaking English, you need to be connected, you need to understand. And the thing I put in the chat, a lot of it is actually from my experience working in partnership with social care, with education and others, is we within health don't understand the beast that health is. So how are we then kind of expecting our parents to actually navigate? And also, why is it that we've actually kind of I'll flip the question around. I said we kind of keep talking ourselves as a very inclusive society. But are we truly inclusive if we actually are then saying parents need to be advocating rightly so to the right thing? They should have agency. They should know how to navigate things. So I mean, why are we making it a battleground for parents where actually every day is a battle? Why don't we actually take away that, where actually parents, we need to offer? So, I mean, I worked with an exceptionally brilliant clinician up in Bradford when I did 6 months of training there, who actually, I mean, and to be honest, I'm yet to come across another such clinician in the next 15 years now. Actually, you know, he would kind of tell parents, actually, this is where you've been wronged by the system. This is how you need to approach it. This is how you actually are entitled to because of how the system has wronged you. We actually kind of seem to, like you said, create a battlefield for parents to kind of, you know, go through that journey. So if you can't speak English, you're out. So I'll give you an example. So I've actually sat through a cost improvement program, okay, and this is within community, within therapies, which said you need to answer 4 questions. Does the child have a condition where intervention from a therapist will help? Yes. Is there therapy available? Yes. Can actually parents bring the child to the clinic? If the answer to all 3 is yes, then the child is offered something. So actually, we've in just those 4 questions, you've ruled out the most vulnerable children that actually can't come in a timely manner, don't understand, can't kind of do the bits that they expect you to do at home. So how is that actually beneficial for the wider population? So I think your kind of question is, I think what we need to do is we need to kind of take away this battle scenario we've created for children with complex conditions and special education needs.
Yeah, wonderful. Thank you, Dilip. Rhea would like to come back and say something.
No, I was just going to go on from that because talking about that 1, 2, 3 thing that you were talking about earlier, you said that you would signpost them to the relevant charities, but let's say you have your parent struggles to speak English, or, you know, when you do signpost them and you give them the contact details for said charity, like how are you going to make sure that they're actually contacting and getting the proper help, if that makes sense?
So Hannah, do you want to come back on that in terms of what your experience was like?
Sure, yeah, that's a really good question, Rhea. And actually that information has been quite hard to get. So we have tried in many ways. It's really difficult. I think, so basically at the WHAMinar, personally, I tried calling all the patients to see what they'd accessed afterwards as a follow-up. And actually I wasn't able to get through to a lot of them. And actually if I had got through, I think the ones that spoke English were obviously the ones that I could get that information from. So that, again, it's very difficult to capture that. And at the WHAMinar, we partnered with the patient and public engagement team and invited everyone who had that leaflet, like invited 100 people to come to this workshop. And actually only 2 of them, including Grace and her friend, came. And we also grabbed lots of people opportunistically from the waiting room. So, but actually, I've learned how not to try and access families who are experiencing health inequalities, and that is probably through expecting them to fill out an online form and then come to sign up for an online workshop and then come again to this hospital at like some random time in the school holidays. It just doesn't work, and we need to be going to families. And the next step, actually, Rhea, is going to schools. Going to special educational needs schools or schools in areas that have a lot of health inequalities, and asking them, like, what were you able to access and what was really helpful. But going to where the patients are, going to where the families normally are, is probably the only way we can do that effectively. So hopefully I will have an answer to that soon, but it is really hard to capture that. And yeah, and actually those suggestions to go where the patients are, go to children's centres even, that was like a suggestion from one of the parents from the workshop. So it's hugely valuable actually having these conversations.
Wait,
yeah, thank you. Thanks. Go on, Ray.
But I was just like, when you're talking about all of that, do you not work closely with someone that liaises between like you and the parent and the charity itself, so that they can essentially follow up and you wouldn't necessarily have to? Because if you listen to someone like Grace's experience, you could tell like she's pretty frustrated. So why would she want to outwardly come up to you and tell her like how frustrated she feels? Do you see what I mean? Like, because obviously she will have a different perception of doctors from her own experience. So why would she want to help, like go out of her way to help? Does that, if that makes sense?
Yes, totally. And I think what you're getting at there is that like the reality for someone like Hannah who's trying to do that work is that there isn't the resource to have somebody like that to be that interplay necessarily. Or, you know, maybe that's the idea that we need from people like you to kind of like be like, oh, why don't we try this? Why don't we try some kind of intermediary? Although there are obviously all sorts of intermediary roles in medicine. Like some services benefit from things like community link workers, but not all services. So that's the thing to know, Rhea, is that the system is so fragmented and so different across the country that not every place benefits from the same kinds of even staff members. So Hannah, you might want to say something about what's happening with you. Yeah.
So I think there are definitely those links in some areas. So GPs have social prescribers, and actually we're piloting in the WHAMinar a family support worker who comes to the complex patient clinic appointments actually, and they very much will do that follow-up work. But that's a pilot, but that's hopefully it'll show that this is really valuable, and then that will be more mainstream practice. But we're trying to build in those links, absolutely. And yeah, it is a really good point.
So I think Mary looked like she wanted to respond kind of to an immediate point, and then Dilip has had his hand up for a little while. So Mary first.
I just wanted to say around so if you design the system around the patient, the child, like, so for example, education, brilliant idea. Yeah, so you go into the schools, but we've had, so if you're not in school, so that child that Grace helped the mum get the child in school. So if you're not in school, you then don't get education, but then you don't get health. Yeah, so you're doubly disadvantaged. So I think the unintended consequences of designing a system to back off another system, you have to think about it a little bit. But I think I think there's a lot of things that we need to reimagine health in the way that we deliver it, because everyone will have Googled their symptom before they even see their GP. By the time you get I think the way that we think about healthcare is very different. And I think there's also the impact, you've not talked about it, but that digital poverty around access to internet and access to, so actually there's language, there's culture, there's digital poverty, and there's almost like a two-tier, isn't there, access to health? So there's like one tier of people who will have Googled it, phoned a friend, gone to see their GP on a video call, sorted it all out, and they will interact with healthcare services very differently to someone who can't speak English very well, doesn't really understand the system, maybe is new to the country, etc., etc. So I think it's just allowing for that difference rather than designing something that fits every, the way we see it, kind of thing.
Yeah, totally. Because if we start deciding what is normal, we're going to just create different types of inequalities, aren't we? That is exactly the problem. Dilip, sorry, you've been so patient.
Thanks, Goody. Yeah, to answer Ria's question, I think, and I think Hannah also likewise has kind of alluded to it. I don't think any one specialty or any one kind of discipline will manage it. For a child with complex condition, it is always a MDT approach. So to answer your question, there have been some places that I worked where actually they've got what's called a child development center coordinator. So that coordinator will actually sit in for, a weekly kind of discussion on, the patients they saw last week and the patients that are coming up in the week following, so that, you can then signpost to say, for example, this child has not kind of come to the physiotherapist appointment. So they would actually say to the clinician, if they do come in, can you just check on, their degree of spasticity and let me know if I need to see them soon. So likewise, there might be somewhere actually they've said they didn't come to this appointment because mum was unwell or things like that. So you can actually kind of tailor that encounter likewise. And to answer your question, how do you kind of close the loop? Now, that's the biggest challenge we've got in the NHS. We don't do it even within health, but you're right. So if the clinician, say, if as the consultant, I keep looking at all of that, my job plan will not give me the time, the necessary or the resources to be able to do it myself. And that is where the MDT approach will help. So if you have somebody like Hannah said, a family support worker, Mary will kind of tell you that having an in-house social worker has definitely helped in conditions where actually children were on the hospital waiting for a response from social care, and having a social worker employed within the hospital helps navigate social services, which you and me probably don't have the skills to do. So, and that is where a MDT approach will help. So if as a clinician, I want to do everything myself, then probably I'm failing all my patients, is the way I look at it.
Yeah. Brilliant thoughts from everybody.